Welcome back to the ProPA podcast. I'm your host, Prof. G, and you're listening to another high-yield episode of our MSK101 series, where we walk through the musculoskeletal and rheumatologic section of the PANCE blueprint one topic at a time. In this episode, we'll be covering polymyositis and dermatomyositis, two related inflammatory myopathies that commonly show up on exams and in real-world practice. We'll break down what they have in common, how they differ, and what key buzzwords to remember. Let's dive in. Did you know that dermatomyositis isn't just a skin-deep disease? Up to 25% of patients with dermatomyositis may have an underlying malignancy, especially ovarian, lung, pancreatic, or gastric cancer. That's why a thorough cancer workup is crucial. All right, so first let's look at the kinder patho. What is polymyositis and dermatomyositis? Well, these are both idiopathic inflammatory myopathies characterized by proximal muscle weakness. The key difference lies in the underlying immune mechanism and the presence or absence of skin findings. Polymyositis is caused by CD8 T cell mediated direct muscle fiber injury. Dermatomyositis involves immune complex deposition and complement-mediated vasculopathy, especially affecting the skin and the muscle. Both can involve systemic manifestations like dysphagia, pulmonary involvement, and fatigue. So let's break down how each of these patients would present clinically. First, let's start out with what they share. They are both progressive, symmetric proximal muscle weakness, and we usually see it more in the shoulders than we do in the hips. Difficulty climbing stairs, rising from chairs, lifting objects, or brushing their hair. They also have no facial or ocular involvement, and this helps distinguish it from myasthenia gravis. Now, there are a few symptoms that are dermatomyositis specific. One is that heliotrope rash. This is a violaceous discoloration around the eyelids, also called a raccoon rash. We also see the Gottron's papules, which are raised scaly patches over the knuckles. We can see a shawl sign, which is a rash over the shoulders and upper back. A V sign, which is a rash over the anterior chest. Patients also have photosensitivity, and they're more strongly associated with malignancy than polymyositis. All right, now for the workup and diagnosis. First off, we're going to see an elevated CK or creatine kinase and aldolase. We'll also notice elevated AST and ALT, and it can look a lot like liver injury. An EMG shows myopathic changes, and a muscle biopsy confirms the diagnosis. For polymyositis, we're going to see endomysial inflammation with CD8 T cells, and for dermatomyositis, we're going to see perivascular and perimysial inflammation with CD4 T cells and complement deposits. Now let's look at the autoantibodies. First off, we have the anti-Jo1, which is associated with interstitial lung disease. Then we have the anti-My2, which are more common in dermatomyositis, and they're often ANA positive. One other thing to mention, cancer screening is definitely recommended, especially with dermatomyositis. All right, now for treatment. First line, we're going to do corticosteroids and high-dose prednisone, followed by a taper. Second line, we're going to consider immunosuppressants like methotrexate and azathioprine. We also need to encourage our patient to have physical therapy. This is important for recovery of the strength of the muscles, and we need to encourage sun protection and topical steroids for dermatomyositis skin lesions. Don't forget about cancer screening and management if associated malignancy is found. All right, now let's look at the book med versus the street med. So book med is going to tell us there's a classic skin findings plus proximal muscle weakness, and this is going to equal dermatomyositis. No rash, that's going to be polymyositis. You're also going to see an elevated CK, a biopsy will confirm it, and steroids fix it. All right, now for street med. So you might get a vague complaint of, oh, I just feel weak or I can't lift my arms like I used to. And you'll need to ask the right questions and not get distracted by normal liver function tests. Check a CK also. And don't forget to ask about photosensitivity or visible rashes, even if the patient doesn't bring them up. All right, some quick clinical pearls to wrap things up. Think proximal muscle weakness without pain. Dermatomyositis equals muscles plus skin. Polymyositis, muscles only. Elevated CK and aldolase is hallmark in laboratory findings. You're also going to see an anti-Jo1, which is associated with interstitial lung disease, and always evaluate for underlying malignancy in dermatomyositis. All right, now it's time for some PANCE practice questions. Question 1. A 47-year-old woman presents with progressive difficulty climbing stairs and brushing her hair. On exam, she has a violaceous rash on her eyelids and scaly red plaques on her knuckles. Her CK and aldolase are elevated. What's the most likely diagnosis? Is it A, polymyositis, B, dermatomyositis, C, systemic lupus erythematosus, or D, myasthenia gravis? I'll give you a few seconds. If you said B, dermatomyositis, you've been paying attention. Classic skin findings plus proximal muscle weakness equals dermatomyositis. All right, question 2. Which antibody is most commonly associated with interstitial lung disease in inflammatory myopathies? Is it A, anti-double-stranded DNA, B, anti-RNP, C, anti-Jo1, or D, anti-SCL70? I'll give you a few seconds. If you said C, anti-Jo1, you are correct. Found both in polymyositis and dermatomyositis, especially those with pulmonary involvement. All right, some final thoughts. Polymyositis and dermatomyositis might sound similar, but key differences in their skin findings, malignancy risk, and pathophysiology make them easy to separate once you've got them down. Keep your eyes open for that heliotrope rash or new onset weakness, and don't forget to check a CK. Thanks for tuning in to another MSK101 Clinical Medicine Brief. If you enjoy this type of content, please check out our YouTube channel, Prof G PAC, for more in-depth videos and lectures. Also, don't forget to subscribe or hit follow so you never miss a new episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you soon.